Hi, this is Joanne Hayes. I'm a nurse practitioner at APD Primary Care and also the director of the Diabetes Clinic embedded in primary care at APD. Um, this is the third continuing medical education um, program in a series that we did in the spring of 2023. In this one, we are going to review continuous glucose monitoring and how to utilize this technology in primary care to help our patients to use the data to adjust care plans and how to bill for the interpretation of the data. This is just a reminder going back to the initial program that we did around overall diabetes management, and to use CGM as yet another tool to change how we manage diabetes from the treat to fail approach here, where we never get down to that legacy effect, never getting down to the therapeutic goal. We just kind of keep waiting to add things until they get worse. And we are trying to do the treat to target approach here in APD primary care and using all tools that we have, including CGM, if warranted, to help our patients get down into that therapeutic range and to have early control and the benefit of the legacy effect. So we've come a long way when we think about how we monitor and manage diabetes. So on the left there, you can see the little books that we used to give to patients for them to take notes about their glucose readings, and they would come in with just moments in time with us never knowing what happened in between those moments. And now we have these highly technical tools that give us loads of information. So is continuous glucose monitoring useful? Is it helpful? And we can use any type of monitoring to track care plan to see if it's working. We can use it for safety for people who are on medications that can cause hypoglycemia. Patients can use it for in the moment decisions and also for them to better understand cause and effect relationships of choices. So this slide is sort of the big take-home message. So I really want to make sure that everybody understands this, because this is really paradigm shift. So as we reviewed earlier, we used to just do finger sticks. So we just had these moments in time glucose. And then 25 or so years ago, we switched to the A1C, which is a really wonderful tool for us to see an average over time. And it was a really good guiding tool for us to see about management. But we all know the limitations of the A1C as well. And using continuous glucose monitors has really helped us see that limitation. And so this is just a good example of the differences that can exist within the same A1C. So if you took the A1C of 7%, which is, as we all know, a pretty good A1C, you can see the three different stories here. So in patient A, wow, perfect, 100% of the time in their therapeutic range. Patient B, they're in the therapeutic range about 2/3 of the time, but they're also having high readings, and they're also having quite a bit of low readings. 8% is significant. And then the last patient, which is an A1C also of 7%, they actually are having a lot of highs and a lot of lows, and very rarely in the therapeutic range. Because those highs and lows are averaging out, it's giving them an A1C of 7%. So that A1C story can vary pretty dramatically from patient to patient. And when we're worried about our patient being more of a patient B or C, that's when continuous glucose monitors can really play a significant role in adjusting care. And for some of our patients, using the CGM is a lifesaver, literally a lifesaver. It can help with hypoglycemia unawareness. It can really help with people adjusting insulin doses as well, and to really tighten up control where before they might not have known that they needed that. So just a little bit of research on CGM and how they are helpful. They are helpful. It's not just a fun tool. It does make a difference in diabetes outcomes. And this is highlighting a few of those studies that really show that it gives an overall reduction in A1C and a decrease in hypoglycemia, and also quality of life improvement for patients who feel like they now have more control and understanding of what they're trying to manage. And I think it's important that we not forget about elderly patients and de-intensifying therapy as they age to reduce the risk of hypoglycemia. And using a CGM can often be a wonderful tool for us to pick up on hypoglycemia and adjusting the plan. So studies are showing that with an elderly population specifically, we were able to decrease hypoglycemic events. People were really satisfied with it, and we were able to increase time in range, which is 70 to 180 for this group. And it's also important for us to remember that this group, even though elderly, can still use technology and can get assistance in using technology for some of them. So CGM, continuous glucose monitoring, is the recommended monitoring method when you're looking at current guidelines by the ADA and the European Society. It's the recommended monitoring for people who are taking insulin. And obviously some people that aren't on insulin can really benefit from this as well, but that for anybody who's on insulin, this is considered the standard of care. And the accuracy of CGM is pretty close to fingerstick accuracy, and I'll get into that a little later. And just want to point out that often we have a bias about who might benefit from this type of technology, and for us to be aware of that and to still offer to patients even when we think maybe not, because I have certainly seen many patients that I have had biases about their ability to do this, and they have been able to. It is expensive for some people, and if insurance isn't covering it, and not everybody needs CGM, but for those that do, it can be a really great benefit. So what are the components of a continuous glucose monitoring? I mean, just generally speaking, they all have some sort of subcutaneous sensor, which is getting the readings. They all have some way to transmit that data to a receiver, which is either a phone, a smartphone, or a reader that they get with the CGM. They have different things that they display. They can do graphs. You can have alerts. They have arrows showing which direction the blood glucose is heading. They can also be shared data. So when someone signs up for these, they can, on a smartphone, they can sign up to have their PCP/CD information. We do have accounts with these different readers or different CGM companies, and or with a family member who can also get the data and help make adjustments and respond to the information on the CGM. So the CGM helps people in real time with the alerts and giving them information, and then after the fact going back and looking at it and looking at trends. So just quickly, just to show you here that the way it works is that it's a sensor that goes into the, with a filament that goes into the subcutaneous tissue, and it is not picking up blood glucose readings, it is doing interstitial glucose readings, and there is diffusion between capillary glucose and the interstitial fluid, and they usually are around the same. There can be a lag time of 2 to 15 minutes, which I'll talk about later, but just understanding that that's where those readings are coming from. So depending on the system that we use, and in this clinic we only use the Libre and the Dexcom technologies. So the sensors can take readings every 1 to 5 minutes, depending on which one you're using. The sensors last 10 to 14 days. They can store up to 8 hours of data. That's just for the sensor itself, not for the readers. If it's Libre 2, the sensor needs to be scanned at least every 8 hours so we don't lose data. And if it's a Libre 3 or Dexcom 6 or 7, the sensor needs to be within 20 to 33 feet of the reader or smartphone in order for it to transmit information. So here, like I've said, we prescribe the Libre and the Dexcom systems. So we're going to just start with the Libre 3, which is the newest of the Libre options. And just recently, just this summer, they added a reader. So now we can prescribe it for all patients. The pharmacies don't have the readers yet, and that should be happening later in the fall, but it is covered by Medicare if we do it through, and actually for Medicare, we would be doing this anyway, doing it through a medical supply company. And with the Libre 3, the main thing here is that we're not scanning the sensors. There's an automatic transmission from the sensor to the reader and or phone. There's lots of reports that are available to patients to look. They get a number. There's graphs. And then this is the, well, let me go back here for a second. Well, on the top here, this is the Libre 2 system. You can see MARD is 9.2%. And on the Libre 3, I think it was 7%. But I'll explain what that means later. It just has to do with the accuracy of the readings. So the Libre 2, again, is a sensor, and it comes with a reader and or phone, but you have to scan the sensor in order to get the readings. That's the big difference. And really, if we're starting anybody on a new system, we should be doing the Libre 3 and not prescribing Libre 2 anymore. And the Libre 14 is their original system, and we should not be prescribing that at all anymore and switching people over to a Libre 3 when possible. The Dexcom, the newest is the Dexcom G7. They also have a G6. If you're starting someone on Dexcom, we would be doing the G7 just because it's a little more accurate and it's a much simpler system. So the Dexcom is similar in that it has a sensor and reader and or phone, and you do not have to scan it. So it's very similar to the Libre 3. It just transmits data directly to the reader and or phone. And this is saying if we're starting again, we wouldn't be ordering a G6. We would be doing the G7. So these are pretty similar platforms, and both actually allow the person to share information with their primary care office, which is us, or with a caregiver. And when we set up the glucometers with patients, we help them set this up. It's just for you all to know, like, especially if you think about like an elderly person and maybe their daughter is also getting the readings so that they can talk to their mom about how to make changes, or if there's any safety issues, the daughter would be getting that, daughter or son, or caregiver would be getting that information as well. So from a patient perspective, what is the CGM experience? So essentially, it's just a lot of information, but this is the phone and or reader where you're getting a number with an arrow next to it and then a graph, and it's showing you when you're in range in the 70 to 180, what your reading is in the moment and what direction your reading is heading. And these are the Libre arrows. The arrows are really, really wonderful tool in making adjustments and planning for patients, because if they're going to get in a car and drive and they check their glucose and it's 90 and the arrow is pointing down, then they know they need to do something. But if they're on 100 and the arrow is pointing up, then they're good. So it is helpful information for their planning purposes. And these are the arrows on the Dexcom system. They just look different. They mean the same thing. We review all of this when we teach people how to use these systems. And these are the different graphs that people can get and review on their own, depending if they're using a reader or a phone. And then the alarms. So the thing that I want to talk about with alarms is that they're used for safety and for learning. We need to avoid alarm fatigue with patients because we want them to pay attention to the alarms. So we want to make sure that alarms are set that are meaningful. So we can set high and low alerts. We can do predictive alerts. We can rapid rise of change setting alarms. But for the most part, when we set up the system with patients, we review that with them and personalize it for them. And we usually keep the, you actually can't turn off the low alerts. So we keep the low alerts on. And then sometimes we turn off the high alerts depending on where someone is in their management. And we usually turn off the signal loss alarm. And that just means if you walk more than 20 feet away, 20 or 33 feet, depending on the system, away from your phone, the phone doesn't start alarming. But the alarms are really helpful for patients to respond quickly and treat highs or lows so that they can shorten the time in the high or low time. And a simple way of thinking about it is sort of like bumpers, like, oh, it's keeping you in that range that is healthier. And you're going to hear a lot from patients about the numbers are inaccurate, and can they be trusted? And so the numbers are good, and I'll get into that. They're good, particularly for an overall good view, but there are certain times that they're less accurate. And usually on the first day of using the sensor, the readings are just a little off. If someone is recovering from hypoglycemia, the alarms are lagging behind. Anytime that's rapid rise or rapid fall, there's going to be some discrepancy. And during exercise, it's not keeping up with the change that could be happening with exercise. And sometimes there's interference with different substances, but that depends on the system, and we review that with patients when we set it up. So for instance, like vitamin C can interfere with the Libre system. And sometimes people are having certain symptoms and their readings aren't showing that, and so they should question it and check with a finger stick. I'm going to talk about MARD now, which is mean absolute relative difference. And it basically just talks about how different is it from an actual blood glucose lab value. And right now, these systems are pretty darn good, and they have a MARD of 6 to 7%, which is 6 to 7% off of what a lab glucose would be. And finger sticks for glucometers are around 1 to 2%. So there is a difference there, but it's very small and doesn't necessarily have a clinical or therapeutic significance. So it is important to review this with patients if they have questions, but overall, we're getting a really good picture of someone's control. And when should they double check? Obviously, if they feel like something's off and this isn't recording it, that they would want to double check. And if the system's telling them to check because they're reading, they're heading down, or if they have a signal loss, if they've left their reader or their phone someplace, then they might want to also double check with a finger stick. And just to review lag time. So lag time has to do with the fact that this is interstitial fluid glucose and not blood glucose. So because there's diffusion from the capillary blood to the interstitial fluid, that can take time, 2 to 15 minutes. And often there's a steady state. There's they're equilibrium, so they're about the same. But when there is a sharp rise or sharp fall in blood glucose level, it's going to take some time for that to be translated to the interstitial fluid. And so if someone is having, after eating, the blood glucose is going up quickly, we know there's going to be a lag time. And if someone just took insulin, we know there's going to be a lag time because the blood glucose will be dropping more quickly than the interstitial fluid will. But within 2 to 15 minutes, the interstitial fluid is picking up those readings. So again, really good for the big picture. But if you're making med decisions at a time of extreme change, so arrow straight up or arrow straight down, you might want to go to a blood glucose reading. And then important in here too is if someone has their low alarm goes off. So if someone has a low interstitial glucose level, meaning that their alarm goes off, it's likely that they've been low for a little bit because it's the blood glucose that the blood glucose went low, and then it takes a little while for the interstitial fluid to get there. So when someone corrects that low reading, that sensor low reading, it also takes time for the sensor to pick up the change. So I usually advise people to go to finger sticks if they have a true low and they're correcting it with food. Go to a blood finger stick so that they can see that they're responding to that treatment. And then let's just review the clinician perspective of CGM. So when someone comes in and they've been using the CGM, we are going to be collecting that data, and then we need to interpret it with the patient. So the main way that this is done is through the ambulatory glucose profile, which is the AGP report. And this is the AGP report here. It has a lot of information on it, so we'll kind of go through this together. So the top part, all AGP reports, the Dexcom or the Libre, have all the same data points. They might look differently, but the same data points are in the report. So over to the right, you'll see the, if I can get that highlighted here. Yeah, so right here, this is sort of the overall picture where you have time and range, and then high, very high, and then lows. And here in this gray box here, it's telling you what the goals are for those ranges. So it's right there on the report. It's telling you if they're using their glucometer regularly and what their average glucose is. The GMI, the glucose management indicator, is a really nice thing to review with patients. It's basically an A1C, but it's just taking that average glucose and turning it into an A1C. We know that it's not truly an A1C because it's not testing. It's not a blood test. It's just taking an average glucose and giving it an equivalent A1C reading. And then this number here, the glucose variability number here, is really important. This is where we get the data on the variation of someone's glucose reading. So that back to that slide in the beginning where you had a 7% A1C and really different reports, the variability is where we get that. So this person, has a 7.6 GMI, which if you were just to look at that, it's like, no, it's not bad. It's not great, but it's not bad. But now they have a very high variability. And so really this is looking okay because they're averaging out highs and lows. So this is a number that I always look at with patients, and we're trying to get below 36%, and some places say below 33%, but it's a really good thing to look at with patients. And this also is going back to personalizing care and time and range. For the most part, we want everybody to be in the 70% greater, 70% or greater range. That would be the equivalent of like an A1C of 7 or so. But for some of our patients, we need to lower that because of their risk for hypoglycemia. And for some of our people, we might want to actually tighten that up a little bit depending on their story. This is just the equivalence on average of the time and range. So if your time and range is 70%, it's about a 7% A1C. But again, knowing that there's quite a bit of variation in there. And the other parts of the report are the overall all the readings put into a graph with the median reading in the dark line here. So it helps you kind of see trends, maybe where they're going high, time of day, or low. These are other reports that are available. This is the one we just looked at. Then there's also the spaghetti report, which is basically just all the days overlaying each other. And then the daily graph, which I use all the time with patients. And I'll show you a bigger picture of that too. So the other thing to look at is the hypoglycemia report. This is under Snapshot and LibreView. And seeing the times of day where there is hypoglycemia is really important to review, and we will be copying these things into the chart as well. And here is the daily graph. So when I'm meeting with patients, I go through each day and kind of see what's going on and look for trends. And also look for like what happened on this day. It was really great. What was different, and eliciting information in that way as well. This is the glucose pattern insight. This is available on the Libre system. I don't really use it, but if you were interested in using it, it pulls up patterns based on an algorithm, and then it suggests things that might be contributing to, if there's lows, is medication contributing to it? It will give you some suggestions of things that could be contributing to the readings that that patient has. So this is a lot of data to review, and so one way of reviewing it is using this algorithm of or this, what's it called, anyway, using data, DATA, to approach reviewing CGM data with a patient. So first you're downloading, then you're assessing for safety, looking at hypoglycemia, you're reviewing the time and range, areas that need to be improved, and then coming up with an action plan. So how are we doing this at APD? It's really hard to incorporate this data and this technology into primary care. The diabetes clinic has been working really hard on this for quite a while, and we've landed in a pretty good place. So I'll just go through what this is looking like at APD right now. So first of all, ordering a CGM. So if you and your patient decide that CGM is a good tool for them, it varies on insurance coverage a lot. Medicare, you have to be on insulin at least once daily, but other private payers, it's really variable depending on their plan. And it's also quite confusing where those orders need to go. Some have to go to the pharmacy and some have to go to a medical supply company. So what we have done is we have providers do not order CGMs anymore. So if you and your patient decide that you want a CGM or the patient wants a CGM, the diabetes clinic will order the CGM for that patient. And right now, Katie Nordman, the diabetes clinic nurse, is doing all orders. In order to have that done, you have to put specific information into your note. So you have to use the dot phrase .apccgm, APCCGM. That has to be in your note, and it will populate data that Katie needs to know in order to put that order through. She'll send the order back to you, and then you sign it. That order then will go to the prior auth team, and they will track the order to see if it's gone through. And then Katie will follow up with that patient and schedule a visit for them to come in. She'll place the CGM. She'll teach them how to use it. And then that patient will either come back to you to review the data, or they will come back to the diabetes clinic to review the data. And you choose that when that information is in the .apccgm dot phrase, whether you are going to be doing it or the diabetes clinic. And Katie will set all of that up. So again, if you want to get a CGM for your patient, put the dot phrase in your note and then forward your note to Katie Nordman, and she will make the rest of it happen. Now you've got a CGM, Katie's placed the CGM, and now the patient's coming back. How do you review the data with your patient? This is happening sort of in different ways, but essentially the AGP report will be downloaded prior to the visit flow staff will do that. Right now we have 2 flow staff working on that, and eventually we'll be teaching other people how to do that. They will download the AGP report and the hypoglycemia report into your note, and you can do that, or if you want, you can get on to the APD CGM sites. We have a Dexcom Clarity site, and we have a LibreView site, and you can pull up that patient data directly and dig in and review it with them. That's actually a really great tool. So if you're wanting to do that, we can teach you how to do that. The flow staff can also print out a hard copy of the report for you. Or if you want, you can actually look at a patient's reader or phone and go through some information as well. Eventually, we hope to have some tablets available so that you can use the tablet to look up information as well with the patient. If you're documenting, so documenting the CGM data interpretation is really done because the flow staff puts the AGP report in your note. But if you don't have the report and you're just pulling things off the phone, or you're pulling specific things off the report itself that you want to review, it's good to put in time and range, lows and highs, and then the average glucose, the GMI, and the variability numbers are good comparison points. And then billing. So if you are interpreting CGM data, you can bill for it, and it's on top of your visit. So if you see a patient for their diabetes, or their diabetes and hypertension, or their diabetes and anything else, you do the visit, and that's the 99213 or 99214 code, whichever is appropriate. And separate from that, you bill for CGM interpretation. And the place that you do that is in charge capture. Charge capture is in the wrap up section of your notes. If you go to wrap up, and then it will have charge capture, you click on that, and then you type in CGM interpretation and report, which is right here, and the code is 95251. You can save it to your favorites so it comes up. But the first time you do it, even if you just type in glucose, or if you type in CGM, this will come up. And then you accept the charges. And then that will just be part of the billing for that visit. This can happen in a patient encounter, but we're also working on this happening at other times too, during IDH encounters or phone calls, so that this bill can be dropped even when you're not doing a visit encounter. We can bill for interpretation, CGM interpretation, every 4 weeks. So if you were seeing someone, sending them off and saying, let's check in a month, I'll take a look, and you went in and looked at their CGM report and then sent them an IDH message about it, you could bill the 95251, and you would just go into charge capture and then pull up that charge. These are some of the payments and RVU numbers for these codes for CGM interpretation, and the one that mostly will affect you is right down here, the 95251, and it's 1.02 RVUs, and average reimbursement is about $98, which is significant. And this is what I already talked about, that you can actually bill this at other times. There are still some glitches here, but go to charge capture, put in glucose or CGM, and that eventually, if it's not happening now, that will be coming up for you to bill. The CGM Pro is another type of system. All you need to know is that it is available. Providers aren't doing it, only the diabetes clinic is doing it with certain patients, where we put on a blind sensor. They're not checking data. We collect the data in 2 weeks, and then we would go through with them. It works for some particular populations, and we do have that available here. And now that's pretty much all the data and information on CGM here at APD. And for people who have watched this, if you're interested in wearing a CGM, please connect with us, and we will make that happen and help you understand what the information means as well. And if you have any questions about CGM and using CGM at APD, please contact the Diabetes Clinic, me, Joanne Hayes, or Katie Nordman, Diabetes Clinic nurse. Thank you so much for listening, and appreciate your time.